Okay, so now we're with Dr. Kathryn Mannix again for cognitive first aid. The stage is yours.
Hello, everybody, and thank you very much for inviting me to join you. I'm going to be talking now about the use of cognitive behavioural therapy in a palliative care and physical health setting. I'm recording this whilst I'm actually working away in Ireland, so this is a hotel room, but I hope to be joining you live from my home later on today at your conference. I trained as a cognitive behaviour therapist in the early 1990s, when actually it was fairly new in its application to physical health. And so I was able to explore in a pioneering kind of way the use of cognitive therapy in a palliative care setting. And what was wonderful was to discover how very helpful it was in helping people not just with emotional distress, but also sometimes in solving some of the physical problems and challenges that they were needing to deal with. So let's talk about the concepts in a little bit more detail. As you're probably aware, cognitive behavior therapy, or CBT, began as a talking therapy for mood disorders, usually for depression, anxiety, and is a shorter term psychotherapeutic intervention than its predecessor, which was analytic psychotherapy. It's very problem focused, it's goal focused, there's something to be achieved. And it's highly effective for depression, anxiety disorders, obsessive compulsive disorder, PTSD, variety of other things. But gradually, it's beginning to prove itself and is now well established for helping people to cope better and more productively, and also to deal with symptoms when they are dealing with a physical health problem rather than an emotional or mental health problem. So the sorts of things that we can use CBT skills for in our physical health practice include things like finding new ways of understanding and then responding to the distress that patients are experiencing in our routine practice. And that might be the person who's suspicious of taking morphine, or the person who's worried about collaborating with wheelchair-based living because they're still holding out hope, despite the fact that they are now paraplegic, that they might walk again one day. So the skills training that the team I've worked along with and I have devised together is something we're calling CBT first aid skills. We're teaching it to physical health practitioners, not to make them into CBT therapists, but not just to give them an additional communication skill set. It's much more practical than that. And what we know now is that teaching people through this combination of theory and practice and reflection on using the skills back in their own workplace really does change their behaviours, so that we can see on tapes how their communication has changed from being already usually very good to including components of CBT as part of their routine communication with patients. So if I was there with you right now, I would ask for some volunteers so that we could do an experiment. Instead of that, I'm going to describe the experiment to you. And I recently had the fun of doing this experiment when I was talking about CBT with palliative care practitioners in Lisbon, in Portugal. And a few kind people came forward to join in the experiment with me. So my volunteers, or guinea pigs, depending on how you look at it, and I each had a balloon, a party balloon, a children's party balloon, and we all blew up our balloons to be as big and as tense and as tight as we could, and we tied a knot in the end of our balloon. The volunteers weren't quite sure what I was going to ask them to do. They were standing on the stage in front of their peers, and they mainly looked a little bit awkward. There was a little bit of shuffling from foot to foot, a bit of grinning and not sure whether to look at the audience or look at their feet. And when I gave them balloons, they started to giggle, and they really looked a little bit nervous. They looked far more nervous, though, when I asked them to do the next thing, which was take the knot in the end of their balloon and put it between their teeth. So the balloon was now sitting right in front of their faces. I then explained to them that I was in a moment going to ask them to close their eyes. But before they closed their eyes, I wanted them to see how big the pin is in the rather lovely brooch that I was wearing that day. And I undid my brooch and I showed them the very sharp pin. Now you could see people's faces looking quite anxious as I asked them please to close their eyes and then to notice how they were feeling, what their bodily sensations were, what the emotions that they were aware of might be, whether there were any thoughts in their minds. As I walked backwards and forwards in front of them, and I also asked them to notice whether their thoughts, their emotions, their bodily sensations changed depending on how close to them with my pin I sounded. You can imagine this was causing great merriment in the audience at large, who were all now very glad that they hadn't volunteered to be guinea pigs for my experiment. So I made my guinea pigs suffer for a few minutes, I do admit, by walking backwards and forwards with my pin. And then there was a very loud bang as I burst my balloon, and all of my guinea pig volunteers jumped with the shock of it. And then they were invited to open their eyes, and we did a debriefing exercise. So here's what we discovered during the debriefing exercise. What I wanted to do was get them to think about the different components of the cognitive behavior therapy model. So first of all, we talked about the thoughts that were going through their minds. And they said things like, I was worried that I might look silly, or I was very aware that I needed to keep myself feeling calm. One of them said, I was frightened that you might pick me, so I was worried. And what I thought was, if she picks me and she pricks my balloon, it will explode in my face. And so when we clarified that, that person's thought wasn't just words, it was actually the physical sensation of how it might feel if the balloon was to explode in their face. So that explosion sign there is just to remind us that people don't only think in thoughts. They think in pictures and in little video runs and in physical sensations of predicted ways that things might happen. And all of the guinea pigs said, yes, they were thinking all of the time, how close is she to me? How safe am I? What do I need to do to protect myself? So these were the thoughts that were going through people's minds as they were helping with the experiment. Those thoughts were related to the emotions that they were feeling. So people who were worried that they might look silly felt a little bit embarrassed, but also found it a little bit amusing. People who thought that I might pick them and that then something unpleasant would happen to them felt stronger emotions of anxiety or even fear. In the past, when I've done this experiment, I've had at least a couple of people who've been quite put out that they volunteered to help and that they felt that I had done something unkind to them. So people have admitted to being angry that they are being treated unkindly by being made to feel afraid. And one person said, actually, I just wanted to know what was going to happen. I felt quite excited about it all. But you can see, can't you, how the thoughts in the first box relate to the emotions in the second box. So that's the first part of the theory. Emotions don't just happen out of nowhere. Emotions are fed to us by thoughts that we may or that we may not be aware that we're thinking. We went on to think about the behaviours that we in the audience had observed whilst they were volunteering for us. So their uncertainty translated itself into giggling and laughter, but also they noticed themselves that they were focusing on their own behaviours. They were focusing on their breathing, trying to be more relaxed, or some of them were focusing on staying safe and defending themselves, and they were aware that they were tensing their muscles, and what we could see was that their shoulders were rising and that some of them were standing with their arms folded across their chests. They were listening very carefully. So one of them was standing with his fists clenched at his side, trying to be strong and brave. And although they were told not to peek, as always happens, at least one person secretly opened their eyes to check where I was and whether I still had the pin. The last component of the model that we're thinking about for cognitive behavior therapy is what our bodies are doing, those bodily sensations, perhaps of anxiety and adrenaline rush, fast heart and a sense of palpitations, or trembling and muscle tension, or that strange feeling like you're in a lift that you might get in your tummy that we call butterflies. Or we could notice that people felt restless and fidgety, and some people were very aware of the taste and the smell of the balloon. So this breaking down of the person's experience into these four components, thoughts, emotions, behaviors, and bodily sensations, arising at a particular moment. So in this instance, standing on a stage, being a volunteer with a balloon in your mouth and a crazy lady with a pin walking around beside you. This is the formulation that we use to help us and our patients to understand what it is that they're experiencing. So we think a little bit about the theory. The theory tells us that thoughts and emotions, behaviors and bodily sensations all interact with each other. And we know that it's not very easy to change our bodily sensations or to decide not to feel particular emotions, but we can learn to recognize them and respond to them intentionally. More particularly, though, we can learn and we can teach other people to learn to recognize their thinking and to recognize when it's not helpful to them. And we can also learn and help other people to learn to notice their behaviors, often behaviors that they're doing to try to solve the problem, but actually that are unhelpful behaviors that often are maintaining the problem. The next important part of the theory is that we are used to thinking, we are used to stuff going through our minds, but not all of our thoughts, in fact, are true. Just because you think it doesn't make it true. Just because I believe it doesn't make it true. And some true thoughts aren't helpful. So, for example, we meet, don't we, lots of young parents who are very sad about the idea that they're not going to survive to guide their children through to adulthood. And that's a true thought. It's a true thought that can be helpful or unhelpful depending on how that person uses the thought. If they allow that thought to intrude and make them sad and anxious anytime they're interacting with their children, then it's an unhelpful thought that stops them from parenting well and from building good memories with those children for their future. But at other times, taking the thought that they're not going to be around to support their children in the future and starting some work to write letters or prepare memory boxes to support the children in their bereavement, now that true thought is being helpful. So it's not the thought itself, but what we're doing with it that really matters. So cognitive theory tells us that we can learn to notice these thoughts and then challenge them either because they're just not true or because they're not helpful in these circumstances, or distract ourselves from those thoughts so we focus on something that's more useful to us. And to do all of these things in a way that's kind to ourselves, rather than blaming ourselves for being silly and thinking that way, to say, of course somebody in these circumstances will think in that way, but what can we do now that's more helpful and more comfortable? So here's a scenario broken down into those components. Here is a mum who has had an argument with her young adult son. He still lives at home, and after the argument, he's raced out of the house, jumped onto his motorbike, and driven away into the night far too fast. And she's left at home feeling terrible. So here are the thoughts that she's having. I'm worried that he won't come back, that he will leave home, that he will go and stay with friends, that he won't be safe, that he'll crash his motorbike. And then she's thinking, he's been out for a long time. He should call me. I can't stand this level of anxiety and concern. And then the self-blame thought of it's my fault. I should have stayed calmer. And many of us will have these thoughts after we've had a disagreement with somebody. But her disagreement was with her young adult son. He also has a responsibility for the conduct of that conversation. So although her lack of calm may have contributed, it's possibly not the whole truth. And maybe his response also contributed. So those are her thoughts, and they are leading to emotions of fear. She's feeling frightened about what might happen to him. She's feeling angry with him for having behaved so badly to her. And also she's feeling angry with herself, which comes out as guilt, that she feels she should have behaved differently. And whenever we hear people using the word should, we listen for anger, blame, shame, and guilt. What I should have done, what I should not have done, what you should have done, what you should not have done, how the world should be. So those are her emotions. And then what's her body doing to her? Well, her body has just got the jitters. She can't concentrate on anything. She can't settle. Her tummy is churning. She's getting abdominal cramps from the anxiety that she's feeling. And in terms of her behaviors, although she's trying hard to distract herself and keep herself busy, she keeps watching the clock. She keeps checking her phone to see if there's a message from him. And of course, every time there isn't a message, she goes back to those thoughts of something must have happened. Is he all right? Is it all my fault? And she goes around this loop all over again. So it's a beautiful illustration of the interaction between thinking, emotions, physical sensations, and our behaviors. And it shows us that cognitive theory is not just about illness or patients, it's just about people and the way we're wired. Thinking about our behaviors is also useful. We can learn to notice what our behaviors are, and then think, is this really helping me? Could there be a different way of approaching this? And one of the things that we do in cognitive behavior therapy, the behavior part of it, is devise with our patients experiments they can try out to modify their behaviors and see what happens when they try doing something different instead of doing what they have previously been doing. So these aren't suggestions from us, these are collaborative ventures that we come up with our patients. So here is a patient who's an elderly man with prostate cancer, and he is becoming progressively more withdrawn and socially isolated. He's got quite a lot of pain, but he is too worried about morphine to take it. He thinks it's a dangerous drug. He thinks that if I take it now, then when I have more pain, and I'm bound to have more pain later on, is he? If I take the morphine now, it won't work when I need it more. But the amount of pain I've got shows how much sicker I am. I'm becoming a burden. I'm spoiling my family's lives. Now, I know you will all have met people who have those sorts of thoughts. And what are the consequences emotionally for this man of his belief that morphine is dangerous and that it should be reserved until later in his illness? Well, it means he's experiencing pain, which is stopping him from going out, so he's lonely and he's sad. His thought about getting sicker is making him frightened, and his thought that he's spoiling his family's lives is making him feel guilty. Physically, the pain is bothering him a lot of the time. It's interfering with his sleep. We know that tired people have less energy, so that will feed back into his thought that he's getting sicker. He's feeling tired all of the time, and he finds that he's quite tearful. And so he continues with his behaviors of avoiding taking the morphine and not going out in case he has pain while he's out, but also not asking for any help. So you can see that he's trying to be brave. He's trying to not be a burden on his family. He's trying to save the morphine for when it will be, he believes, the most useful for him. And he's trying to avoid needing the morphine by not being active. So he's taking problem-solving actions like not going out. and he's taking dealing it with it myself actions by not asking for help. But all of those behaviors simply mean that he doesn't take the morphine, he continues to have pain. The pain continues to make him feel that he's sicker than he actually is, interrupts his activities of daily living, interferes with his sleep, and sends him back round the cycle again. So we can see that we could do some testing of his thoughts about how dangerous morphine might be, perhaps by introducing him to other patients in the service who are taking morphine and are thriving, or perhaps now by addressing these behaviors, by talking to him about an experiment of what dose of morphine might it feel safe to take. Might he feel safe to take a small dose on a morning when he knows he's coming up to see you in the hospice? So if it does have terrible side effects, he knows that you'll be there and you'll be able to help him. So can you help him to devise an experiment that he feels safe to commit to, that tests his belief that morphine is dangerous and helps to disprove his theory, or actually helps you to know that he does get rotten side effects from morphine, so you can help to moderate the side effects. The really important thing about an experiment is we're not trying to prove to this person that they are wrong. We're trying to work with this person to be more curious about what would happen if they tried to do things differently. So the key components of taking a CBT approach are that it's collaborative. There are two experts here. One of us might be an expert in palliative care and maybe an expert in cognitive therapy, but the other is an expert in being this person, living this life, who understands their family dynamics, who understands what their beliefs and expectations are, who understands what it's like to be living their life. And we're combining our expertise to help the patient to test their thinking, to experiment with new behaviors, to see what might happen. And so we're grounded in curiosity. We are not trying to prove a point. We're curious about what is driving this current situation and what might be different ways to think about it. So by talking to the person and getting them to explain to us what happens in a particular situation, we can start to break it down into the thinking, the physical sensations, the emotions, and the behaviors, and then help the person to be curious about how each of those things links to the others. And very often at this point, I give the patient the pen and ask them whether they'd like to draw arrows where this thought drives that emotion, where that emotion drives this physical sensation, where awareness of that physical sensation makes me think again about my illness and that kind of thing. And then anything that we try to do to modify what's going on are based on that formulation. To do that, of course, requires a huge amount of trust in us by our patients, and it requires us to work collaboratively with them to explore their thinking, and particularly to explore the thoughts that are associated with the most distress. That means doing something that we might find a little bit uncomfortable. When a person is talking to us about their situation and they are talking about the thoughts that go through their mind, very often the thoughts they tell us are the thoughts that they believe are acceptable. But inside their minds, perhaps buried even from their own discernment, are more distressing thoughts, thoughts that we call hot thoughts, that drive their deepest distress. So when the patient begins to be more distressed during the conversation, that's the time that they're most likely to be able to go into their head and find what that distressing thought is. So I might notice that my patient is becoming increasingly distressed and say something like, I can see this is really difficult for you and I'm sorry that it's so distressing, but I'm really curious to know what's going through your mind right now. I can see you're tearing up. Sounds as though this is really difficult for you. What exactly is going through your mind that's driving those tears? And you'll be really surprised what might come up. And you'll also be really surprised at how helpful patients can find it to say their hot thoughts out loud. Similarly, it requires a lot of courage by our patients and support from us for them to experiment with doing something different when they feel so vulnerable. Trying a new behavior To replace an old behavior is a risk, and we need to be understanding and supportive as we ask them to do that. So this is the formulation we're talking about. If you ever talk to proper cognitive therapists, they refer to this as the 5 areas model. In our course, we very often refer to it as a hot cross bun because it looks like a bun that we have here in Britain round about Easter time that has a cross on the top of it. So it's bun shaped with a cross. So let's think about this 5 areas model for a moment and the way that it might work for a particular patient. So this is a patient that was brought to our training course by one of the trainees who was a very, very senior breast cancer nurse, very experienced person. And she was working with a woman who'd recently gone home after mastectomy, thought to be cured, and actually was quite surprised when she came back to clinic to find that this lady had not been out of the house since she had her operation. And so she drew out this hot cross bun, this 5 areas formulation from this patient. So the circumstance was that she was thinking about going out to the shops. Why didn't she go? Well, the thoughts going through her mind were that I don't look the same as I used to. I look different. Everybody will notice. People will stare at me. I am never going to feel normal again. And those thoughts drove really huge emotions of feeling anxious about people looking at her, picking her out, pointing at her, commenting about her, sadness about the change in her body, a sense of panic that she might need to leave somewhere quickly and not be able to get out, and loneliness because not only was she avoiding going out, she was also avoiding her friends coming round. She was staying at home and she wasn't even popping out to the shops. So in terms of behaviours, very different behaviours from the woman who'd come into hospital to have her mastectomy. And staying at home gave her lots of time to think about and focus on her body. So she noticed her bodily sensations like the post-operative pain in her scar, the fact that her bra rubbed against the edge of the scar, so that felt uncomfortable. And she also noticed things like dry mouth and breathlessness and rapid heart and nausea. And because she didn't understand that they were symptoms of adrenaline because of her anxiety, she thought maybe the doctors had been wrong and her cancer had spread further than they believed. So this nurse decided to, having shown the patient this formulation, ask her whether she thought she could try out an experiment. And the patient agreed that she would try out an experiment because the nurse was on a cognitive therapy course and she'd been asked to do this. And the patient loved this nurse and wanted to help her. So what they agreed was the patient would plan a visit to a local shop. But before she went there, she was going to write down some scores for how difficult that would be, how much she might enjoy it, and how satisfied she might feel before she did it. And then she would write the scores out again afterwards to see whether her predictions were accurate. So the nurse said, you know, she was really happy to help me with the experiment. And the experiment was to count the number of people who stared at her. And guess what? Nobody stared at her. So here are her scores for difficulty, for pleasure, and for satisfaction when she was sitting planning her experiment with the nurse. So she thought it was going to be 10 out of 10 difficult. I'll feel terrible. I'll be embarrassed. I'm going to be standing, trying to cover myself up. Why would I enjoy it? I'm only popping to the corner shop. 2 out of 10 pleasure because I can buy some new tea bags. But otherwise, why would it be pleasant? And why would I be satisfied by doing something as tiny as going to the corner shop? So only 1 out of 10 satisfaction. And then she took her courage in both hands and did the experiment. And this is what she discovered, that it was a little bit difficult, 6 out of 10, but it was not as difficult as she had thought it was going to be. She was surprised by how much pleasure she got from going out of the house, walking along the street, going into the shop and browsing for things that she needed. And she was really surprised at how satisfied she felt with herself for having tried the experiment. Now, ordinarily, I would ask somebody to try out the experiment and we'd come back to the next session and we'd talk about it together So they might be able to see that their predictions were getting in the way, that their thought predictions were changing the way they behaved. This lady got it straight away. So by the time she went back to talk to her breast nurse, she'd been out into town on the bus to meet her friends for coffee, and that had completely changed the way she was recovering from her surgery. So the key skills that we're teaching to our CBT first aiders are these skills of being curious, not being experts who are telling people what to do, but using questions in the same way Socrates did to ask people to reflect on what they already know to guide them to discover deeper truths about their situation. So it's collaborative, it's curious, and it's inquiring. And it always draws out a formulation, and the formulation changes as time goes by, as the person themselves starts to change. We work towards particular goals. So for this lady with breast cancer, her goals were to be able to see her friends again and enjoy their company. And they're all about empowering change by experimenting, by challenging, by finding out, by putting curiosity into practice, and then recording things so that we can measure the changes. And perhaps just as importantly and very difficult for us as kind, caring practitioners is to avoid reassuring, avoid giving advice, avoid stepping back when the person becomes distressed, actually stepping forwards when the person becomes distressed. So instead of the reassurance of a person getting distressed and saying, oh, don't be upset, I'm sure it's going to be all right, which really says, I don't like it when you get distressed. When the person gets distressed, we say, I see that you're distressed. I'm sorry that you're distressed. I'm curious about what's going on for you when you're distressed. Similarly, the person who won't go out, if we had told her, well, what you need to do is go to the corner shop, she wouldn't have done that. She wouldn't have taken the advice. So by avoiding giving advice and being curious to find out what might happen if she dared to go to the shop, this nurse gave the power to the patient, and the patient realized that she had actually been trapped by her own thinking and behavior and was able to untrap herself. Here's a lady that I worked with who described getting incredibly frustrated and tearful when she was helping her daughter with her homework. This was a lady who had motor neuron disease, which was progressing, and she described having a knot in her stomach and feeling very tearful, that she felt weepy and was really avoiding being with her kids because she couldn't enjoy being with them, and a sense of overwhelming sadness and despair as her daughter was struggling with her homework. And she told me that the thought going through her mind was, well, she should be able to do this herself. Now, can you see that that thought doesn't really match the level of emotional distress that this lady was experiencing? So when I started to ask her about what it was about the fact that her daughter was struggling with the homework that she was finding difficult herself, she started to cry. And so I was able to say, look, I can see this is really distressing. What's going on here? What's the thought underneath that? And the thought was, well, if she can't even manage her maths homework, how is she going to manage her life when I have died? Now that thought fits much better, doesn't it, with her sadness and her despair. So now we need to do some thinking and some work together about what can this mum put in place to support her daughter. Will her daughter be devastated for the rest of her life? What's the evidence about what happens to children and bereavement if they're well supported after a parent has died? Because we know that this girl, if she's well supported, stands every chance of going on to have a normal adult life where she will, of course, always miss her mum, but her life chances will not be ruined by the fact that her mother has died before she became an adult. So being able to find the thoughts is a really important way into working with them, not by reassuring, but by looking for the evidence for and against the thought, or finding more information about the thing that the person is sad or fearful or guilty about. So using cognitive therapy techniques can help us when we feel stuck. It's not something we need to get out for every interaction with every patient. But when we find that we're starting to get into a circle of not being able to move forward, this can be a useful set of techniques to dig into, because it helps us to help our patients to get new insights and to find new ways for them to tackle their distress so they can feel hopeful and they don't feel done to, they feel worked with. It also gives us skills to work beyond places where we might ordinarily feel a little bit uncomfortable to go, like inquiring about hot thoughts. The training won't make us fully qualified cognitive therapists, but it makes us cognitive therapy first aiders. And of the several hundred cognitive therapy first aiders that we've trained now around Great Britain and Northern Ireland, a substantial number of those have gone on to do full diploma or master's level cognitive therapy training. So we've now got new cognitive therapists who can themselves become trainers and supporters of our cognitive therapy first aiders. So thank you very much for listening, and I hope that by now I've managed to join you in real life on the line. Thanks for inviting me.
Hello, Kathryn. Thank you so much for that. Are you there?
Yes, here I am.
Yay.
Hello.
Looks like lovely sunshine come through your window there.
Yeah, the
That was
dawn has risen while we've been together.
Oh, thank you for staying up with us. That was really, that was really enlightening, and being in those stuck situations are quite familiar to us. I think when we've hitting walls, and hopefully this gives us more skills with this CBT first aid that you are teaching us today. I can see that you've very kindly answered many of the questions in the box, which is really helpful. There is another question from Dr. Diana. How do we respond appropriately after a long pause or listening? Should we be the first to break the silence or allow the patient to speak first?
Great question. And it's all part of that conversational dance, isn't it? So sometimes when we're in a conversation, one of the things that we don't think about is that there's something we're doing with our eyes. And that if we watch people in conversation, you'll watch them give each other cues with their eyes, looking at each other, looking down, and we're signaling whose turn it is to talk. You may never have noticed it, but you'll all notice it when you go back and have your next conversation. And one of the things that we do during silence is that rather than giving somebody kind of very close, tight eye contact, which is saying, I'm waiting for you to speak, which puts pressure on them, we often will look downwards. And you'll probably remember really important conversations you've all had when you've been perhaps traveling in a car together or walking side by side where you can't do direct eye contact anyway. So there's something about looking at a person to see if they're ready to speak yet, and if they don't look ready to speak yet, looking down again, which says, I'm still waiting. I'm giving you the floor. It's your turn. Sometimes the pause needs to be broken, and then we can say something like, I can see you. Is there something else you'd like to say? And conversation analysis tells us that if we say, is there anything else you'd like to say? Almost always people will say no. If we say, is there something else you'd like to say? They will think before they say no, because there may very well be something. So there's a long pause. We acknowledge that this is difficult, that it's taking them time to think about it. Is there something else you'd like to say? Are you content to sit quietly here for a moment? Or would you like me to move things on? And so we continue at the dance, we continue collaborating, we continue to ask permission.
I love that concept of dance. It just feels so. It makes sense when you explained it that way. Kathryn, we have a question from Dr. Saifo. He says sometimes we do have the urge to think things like, oh, another one or another patient with this and that, even before listening properly to a new or different patient? And how do we remove ourselves from previous patients or sessions when we have a new patient encounter? I don't know whether this is anything to do with transference or counter transference, but that can sometimes happen.
It's absolutely true, isn't it? It's really difficult to bring fresh me to each new interaction. And I think so. In therapy, there's I mentioned it in the talk, the concept of the therapy hour, but the last 10 to 15 minutes of the therapy hour is not spent with the patient. It's spent reflecting, making the notes, thinking the implications for the next session, things I need to check the next time we meet. But it's also part of finishing being in that session with that person. And so we need to develop habits that help us to do that in a busy back-to-back outpatient clinic, or we're moving around the hospital and we're seeing a patient on this ward, and then we're going a few doors down and seeing another patient, possibly being looked after by the same nursing team, which sometimes also scrambles our perceptions of what's going on in the interaction. So I think being intentional about that, I think that's a really good question. It's a great point that Dr. Latif is making, that we need to actually recenter ourselves before we move on to see the next patient. And when we are distracted by thoughts about a previous patient, to be able to recognize that is the first step in being able to say, okay, you have your place. This is an important thought, but it's not for now. It's in a moment. So it's that, is this a helpful thought or an unhelpful thought? What's perhaps harder, and comes back to the question that I've answered in the chat stream, is the emotion that we carry from one interaction to another interaction to another interaction. And I remember a day of visiting a patient in hospital, teenager, dying, terribly distressed family, and spending 3/4 of an hour with them, and they were weeping and they were saying goodbye to their child, and it was incredibly hard. And I needed to go on from that to meet somebody who was newly diagnosed with widely metastatic cancer on one of the surgical wards, who was a person in their 70s. So it's not nearly as tragic, but it is for this person, and it is for this family. So I mustn't carry that comparison with me, and I somehow have to park my sorrow for the first family in order to talk to the second family. So I think we have to think at the end of each interaction, I've completed the interaction by a moment of self-reflection and self-care, because if we don't do that, we can go down an emotional staircase step by step, and that is the route to burnout. And part of the management of burnout is that the system that we work in needs to be compassionate, but self-care is important, and it's our responsibility.
Thank you, Kathryn. I think that's definitely another skill that we must have, as a palliative care practitioner. There's one last question for you from Kathryn. How do we affect? We were talking about silence earlier. How do we affect this silence in a telephone environment?
Great question, because if you're just silent on the telephone, then the person starts to think that the line isn't still connected, that the call is dropped in some way. So we need to find things to say that are saying the line is still connected, I am still paying attention, without interrupting what's happening for them in their silence, which is their careful thinking. So it's the equivalent of, if we were in a room with somebody, we might just shift our position in our chair, but continue to look towards them, for example, or we'd see them getting upset and we'd pass them a tissue. How do we do that on the phone? And I think it's saying things of that we're making compassionate noises that are not of consequence if the person doesn't give them attention. So, I'm still here. Take your time. Gosh, this is hard, isn't it? There's no hurry. Yeah, I can hear this is upsetting for you. Yes, it's okay, I am still here. None of those things requires them to stop thinking their deep thoughts to pay attention to us. It's what one of my dear friends and colleagues calls umpty umpty noises. It's making noise that signifies I'm still present, but doesn't distract you from the internal work that you're doing. But it's important that we do that. Otherwise, their anxiety that we're not still attached, and therefore that they're not still supported in their place of pain, can start to creep in. So although it might feel a little bit silly, it's actually quite an important thing to do.
Thank you, Kathryn. There is another question, if you're still okay, that's just come through as well from Nurse Iza. How do you manage time to see many patients in a day when, having deep conversations actually take a long time and we may have many patients to visit or see in one day? How do we manage this?
That's a really, really important question. I think that we are seeing very people who are tired and spend a lot of time with them. And I think that after we leave, we may have taken up their energy quota for their day. And we don't realize that they are performing for us. And after we leave, there's nothing left for them to give to their families. So I think we need to acquire a habit of shorter conversations and seeing people perhaps more frequently, but for less time. And so my challenge to us all as palliative care practitioners, because this is my habit too, of, a 1 hour community visit, an hour of somebody's day when they're really unwell is a huge emotional task for them, a huge energy consuming task for them. Could we experiment? Could we try the experiment of saying my visits will be, or at least my conversations during the visit with the patient will be no more than 20 minutes? Very focused, deep attention, listening fully, reflecting, saying back what I've heard, checking whether or not there's something else that needs to be discussed, making a summary and being ready to leave. And my belief is we can do as much work in 20 minutes as we can do in an hour. A lot of the time of our visits is the time that it takes us to arrive, do the greetings, and change from greeting mode into going into deep things mode. And we try to do that imperceptibly. I think we could be more businesslike about it. It's really lovely to see you. I know that you've been worrying about X. I'm here if you'd like to talk about that today. Just name it, and let's go there instead of gradually working round to the reason for our visit. So I'd be really interested if you'd like to all try out 20-minute calls instead of 1 hour calls, and let me know whether in fact major things get dropped or whether in fact you can do 3 things in an hour instead of only 1 thing in an hour. Don't know. That's my challenge to you all.
Gosh, that's amazing. That's another skill we've got to learn then. But no, that's really true, isn't it? Perhaps we could be more efficient in our deep conversations and tender conversations, not necessarily longer with them. I can see Siti Najwa's hand raised. Are you? Oh, sorry, maybe not. Okay, well, I'm. Oh, hang on, Najwa, are you there? Do you have a question? Okay, no, that's fine. Well, I'm so sorry because I know we've gone over time, but I could sit listening to you all day, Kathryn. That was really really lovely, and um, thank you so much. I know you've been up. I mean, what time is it over there?
Oh, it's getting on. It's 10 in the morning now.
10 in the morning. You've been up with us, in the early hours of the morning. We really appreciate it. Most of us will probably, be scrambling to buy your books after this. And I think this is the perfect note on which we end today. It's such a beautiful end to the day. Thank you to all the participants who have stayed with us throughout the day. This has been like 9 hours, some of us 10 hours. Have a good rest. Kathryn, have a good day. A great evening to everyone here in Malaysia. We look forward to seeing you again tomorrow for more exciting topics. Assalamualaikum and good evening.